Welcome, and we'll go ahead and kick it off. Our first speaker to kick off the meeting, none other than the Queen, Nadira Hamid. Yes, you are. Welcome.
All right. So, this year, the organizing committee asked me to talk about advanced tricuspid imaging. And for those of you who attended yesterday's boot camp, thank you. It was our first imaging boot camp yesterday. And we spent a lot of time, and I know my ex-spouses know about it, about the 3D navigation, which I spoke a lot about it and presented on the Mail with Nadira webinar. But I thought this year I want to talk a little bit more about the imaging tips and tricks during the triclip imaging and what we should be looking out for to really prevent this complication. So I'm going to advance my slide, which is not working. Okay, so we have, let me go back. Here, so we have a 69-year-old lady who had previous mitral valve repair with a ring. We have a LAA ligation, and including our pacemakers. We have persistent AFib, obstructive sleep apnea. We literally saw us in the valve clinic by one of our interventionists with severe symptomatic TR. And this patient clearly had CIED-related TR and was seen by our EP colleagues and was not really suitable for lead extraction because it's been in there for a long time and for multiple various reasons from our EP colleagues. And here is our baseline TE imaging. You can see here our basic RV inflow-outflow view during our interrogation. For any TR cases, you can see moving from the anterior to the posterior, color and no color. You see that RV lead across the tricuspid valve, and you can see the lead certainly, right in the center. Is very mobile, there's a lot of slack of it, and you see the TR all around it. So really from a triclip perspective in terms of T-tier, can be challenging, but certainly doable in terms of the gaps. We look at our transgastric view, so you can see here, you can see the mobility of it. There's a lot of slack moving from posterior to anterior. Biplane imaging from the transgastric view on the right-hand side, you can see the mobility of it, and it's really embedded into your subvalvular apparatus. And color Doppler is all around that TR, you can see here. And so we do a lot of this lead manipulation in our cath lab. We bring in the patient with our right heart cath, Paul will do it, and we manipulate it, and I'll do the TE. So you can see here the lead as he manipulates, down anteriorly. You can see the fluoro imaging there. And you see the color Doppler, that there's potential, there is a room for us to put a triclip there. But the question I have for the panelists is, what would you do? What would be the next step, right? Would we proceed with a triclip posterior to the RV lead? Or do you want to re-manipulate the RV lead moving posteriorly? Or just forget about triclip, go for TTVR, or look for other tricuspid technologies, a heterotopic, or just continue medical therapy? Comments, please.
What do you guys think? Nadira, what kind of lead is it? Do you know how long it's been in there?
So pacemaker has been in there for at least more than 5 years.
Okay, so chronic lead, and it's a lead, not an ICD lead?
No.
Okay, so chronic lead, not an ICD lead. Manny, what do you guys do at Piedmont? Extract, not extract? How do your EP colleagues feel about this? Here.
We don't deal with the lead. We leave the lead alone, and we have defaulted to TTVR mostly under a lead situation.
So you jail the leads? No one complains?
We don't find manipulating the lead helpful. I mean, you're left with as much TR, and we don't. I think for T-tier it might make a difference. For TTVR, we have not found that to be important to deal with the lead a priori to the procedure.
Okay, so you would just do TTVR and just jail it?
Yeah.
Okay. So there's a lot of talk about extracting because a lot of people have concerns about the ability to go back in if something happens. Scott, Firas, or either you guys are extracting these before TTVR?
You know, if there's a lead-related issue, the first step we do is just get our EP people involved. I think that's the key for this. There are many, I think, kind of options to work around it, and then you just got to figure out, well, the risks and benefits of each for your patient. So some strategies have been, okay, go ahead. If there's reasonable mobility of the lead, we'll evaluate it pre and post, and then already have a pre-procedural plan for what's going to happen if it's going to be an LV lead in the coronary sinus, or putting in a micro or something like that afterwards. So removal has been done on occasion. That's more when there is, overt kind of leaflet pinning, both in systole and diastole. This one kind of looked like it was more of a systolic kind of, not really impingement, but limiting that anterior motion because it was anterior to posterior directed jet. But I would worry about where it was placed in this. I'm not sure with a TTVR where that lead would go, and while it was flexing back and forth, the ability for a TTVR to fully expand and not avulse that lead or impinge it. So, I'll stop there. I think there are a lot of ways around it, but CT really helps with that. The TE helps with that, but then the lead chronicity and your center's EP experience help with it a lot as well.
Yeah, or Frosty or Lucy, do you want to comment on tier around this? Nadira asked a question.
Just to echo that, if it is lead associated, we will have EPCM, but a lot of times, even if you do extract these leads, the TR doesn't get better. So if we had a patient like this, we would try to clip, and we were going to move forward with the TTR, then we would try to clip around it. I'm just curious why you manipulated the lead anteriorly instead of posteriorly.
Nadira, yeah.
Yeah, so this was a case with both my interventionists in the lab. So there was me going on the fluoro, say, can you move exactly that posterior? I say, move it a little bit to the right. So this is what I'll show you. So they did move the lead. You see, you can see on the fluoro, literally posteriorly. And I said there's room actually to put the tri-clip anteriorly. And if you look at the comparison between the left groin and the right groin, so I'm really changing the axis. So when you see on the left groin, the lead was actually, you can't move it. And you look at the fluoro, and Paul probably can explain a little bit better, is if you change your axis from the lead manipulation of the right groin, you can see the difference on the right-hand side, about 1 centimeter in terms of manipulating the lead anteriorly to posteriorly. So we changed the axis to a right groin, and then we moved the tri-clip onto the left groin. Any comments, Paul?
Oh, yeah. So now I remember this case. So it's actually an ICD lead. And so what was interesting is that if you look at the trajectory of the lead, it goes P to A, and the anterior hump was very hard to reach from the right groin. So it was either an Oscar or Gillis. I think it was a Destino. And this Destino could not be pushed on top the superior part of the lead where it's floating up. So we actually had to go to the right groin with the steerable, and the steerable dropped us closer to the tricuspid valve, and it got us above the lead, which then we're able to pull anteriorly. Does that make sense? Yeah, so the left groin versus right groin access changes the height of the steerable relative to the tricuspid valve, and it allows us to get on top of the lead for the proper manipulation. So.
Yeah. So that's the learning point number one. In the interest of time, then once we move it posteriorly, then we continued as per normal our workflow in terms of tri-clip. 3D MPR, very helpful. in terms of orientation, perpendicularity. Transgastric view, you can see as we manipulate the first triclip anteroseptally in your centrally. Another second learning point that I really want to introduce you is in actually submission to a journal right now is really nailing that IVC offset. We use it a lot, live 3D, as Paul on one of my interventionists will enter into the right atrium. You can see on the left-hand side, the 7 o'clock, if you look at an on phase, I would tell him this is a septal hugger. So you can see as he enters, is really pointing into the septum. And you can see on the right-hand side, the perpendicularity is really a septal hugger. And he did as many maneuvers, and consideration should be taken in terms of access going into the left groin. And for example, in this case, we changed this, another case actually to the left groin. You can see the access from 5 o'clock on the live 3D view. From the bicaval view, you can see the perpendicularity of it, certainly much better in terms of maneuvering into the tricuspid. So this is certainly one of the tips and tricks that we learned, and something you could practice with your imager back home in terms of nailing the IVC offset from a TE perspective, besides CT, okay? So that's the second learning point. In terms of, transgastric view, once we maneuver, orientating the clip arms in the transgastric view, that's the holy grail, then we were kind of, into the offset in terms of grasping view. But what certainly is, looking at here, the fluoroscopy, I put this in because you can see there's so much stuff in there. So thinking of the only missing thing was ice, but we didn't need ice in this case. We will manage to get the transgastric view and the grasping view. The third learning point in this case is really the importance of septal leaflet conformation on your TEE during the procedure. So you look on the arrow on the right-hand side. What do you think? You think it's optimal? Can we optimize it a little bit? I can see Mark Riccardi smiling. He's like, yes, probably need to optimize that. And this is the thing, and you can look on the transgastric view. I want you to remember that image. Look at the gap and the color. Although it's close already, the gap is pretty big, right? And I look at the transgastric view. Me and Paul always say we need at least 2 confirmatory views to make sure that both leaflets are really grasping. So in the interest of time, this is really not optimized. I think the panelists can agree with me on that. So we went ahead and we optimized this. So you can see here, and look at the image, the middle one and the right-hand side. As the movie is playing, you can see, Paul would maneuver on the clockwise just to grasp a little bit of the septal leaflet, and you can see much better grasp of that septal leaflet all the way to the annulus. And look at the transgastric view. Remember the image just now, the gap, much bigger before, and look at the gap here. Certainly much smaller, and the mobility of that septal leaflet is not taut. It's a little bit more mobile now. So you got a better leaflet grasp in this case. And the question I have is, what's the next case? Do you want to put another clip, Mark?
Started right.
There I am telling these guys, I suspect that agilis that you move, that lead, is the issue. So here you go. They let go of the agilis. See what just happened. Yeah. So think outside the box as well. As you have so much stuff in the RA, you are impinging on some cords, subvalvular. So I told Paul, release that agilis catheter, and it just went in. And the color Doppler finally was actually pretty good. And I felt that agilis was interacting with that septal leaflet as you move posteriorly. So you can see it moving very nicely. And the result was actually, quantitatively was mild moderate. It was 21. We felt it was fine. And if there's further residual, we can certainly come back. But we left with this patient, and the transthoracic prior to discharge was literally down to mild. So certainly from massive down to mild, I think was a great improvement for this patient. And so learning points in this case, think about right versus left groin. You're thinking in terms of manipulation. Think, before start pre-procedure planning, the utility of 3D TEE, the IVC offset, is something that I encourage all the imagers to try. And during procedure, the red flags to really optimize the septal leaflet. And if you can't see it in transesophageal, think of 3D ICE. And then my last point, sometimes I feel less is more for the tricuspid, unlike the mitral. With that, thank you very much, everyone.
So Manny, was that a good TTVR result? That might be the first time I've seen a pacer lead or defibrillator lead used as a spacer in the tricuspid position. That was kind of like a spacer technology, wasn't it?
Yeah, I mean, yes, it was a great result. I can't say anything else. I don't know I want to work that hard. That's the important thing.
Oh, he doesn't want to work that hard. Fair enough. All right. Let's see here. Hursh, I think you're next. Thanks so much.
All right. So I think my task Paul gave me was to speak about the unrepairable valve. Can we repair it? Let me go back. Okay. Those are my disclosures. So this is the presentation. An 83-year-old female with shortness of breath, fatigue, abdominal distension. She had 4 heart failure hospitalizations in the last 4 months. Her creatinine was increasing with Lasix. She had a CRT device already placed, even though she had a normal EF. And of course, severe tricuspid regurgitation and mild mitral regurgitation. Those are her right heart cath numbers. Basically, I thought that if she did have TR that we could fix, that she would benefit from it. So Nadira, don't get mad at these images, but I didn't have my imager with me this time, so these are my pre-screening images, so they're not great. But for interventionalists, when we do this, we're like, can we clip it or not? We don't need more images than that. But you can see right now that the lead is kind of obstructing, right? There's severe tricuspid regurgitation. And here you can see that it might be affecting the anterior leaflet. And this is what I thought, and you guys can comment if you want. So my thought was this. So you see that lead there. I actually think it's adhered to something. I can't tell if it's the anterior septal leaflet, but the gap in the middle is big to me. So I didn't think it was going to be a good clip case. I didn't think we'd get an optimal result. So, and then here's another view that's showing that the lead probably is affecting us. So before I talk about this, I'll ask you guys what you would do, or ask the audience what you guys would do.
Lucy, what do you think of those images?
And I will tell you before, you don't have to talk about my imaging, but other than that, so I had done 2 TTVRs before this. Both had late complications, which we know is a signal, right, in that group of patients. One was a late heart block about 3 weeks later from a pacer lead, and the other one was a late pericardial effusion that came in tamponade. So with that PTSD in mind, you can see, you can tell which way I wanted to go.
So we're not going to ask Manny. Lucy?
So a significant amount of TR, I think we'll all agree. And the thing that, I agree with you, the gap or the width of that tricuspid regurgitant jet was pretty wide. So just eyeballing to me, it was at least 1 centimeter wide. So a pretty large gap, especially in that biplane view that you had. So TTVR would probably make a lot of sense for her as opposed to clip. Is she pacer dependent?
She wasn't. She has the CRT device too, so they could have used that. So
Okay.
she is pacer dependent, actually.
She is.
But the CRT, according to EP, the CRT device would be okay if the lead was removed.
I think another thing we have to talk about is her RV size and function. I don't know if we took a good look at that, but assuming her RV size and function is okay, and the gap is that big, and we get an okay from EP, I think it'd be a TVR case.
Do you have a perimeter, Hursh, from a CT or anything?
So I did analyze it. It was a good case for a valve replacement.
For Evoke?
Yeah, for Evoke.
Okay.
So I forgot the numbers, but it was a good case for Evoke.
Farasa, what do you think? You do a lot of Evokes here.
I mean, I have to be careful what I say. I'm surrounded by two echocardiographers and two of the best interventionalists, and I'm going to take your stand on this. But this is difficult for the morning, Paul. You got to get us easier cases for the morning. I think what we have learned is in the EP world, the two things I would like to know first is, one, how old is the lead? Two, how dependent it is. Because that, automatically, if it's a new lead and the patient is pacer dependent, and that can easily, the lead can be removed and leadless pacing strategies adopted. We try not to, we don't move the lead for the, to reduce TR. I think that is proven time after time, including you, Paul, and Nadira and many others, that it doesn't change things. We remove it for the ease of the procedure. And in our practice, we stopped mucking with the lead. I mean, when we started doing tricuspid, the only thing that I knew how to do is how to remove lead. Tricuspid, I had no idea. Like we just move lead because it's fun, pissing off electrophysiologists. But then we very quickly realized that we just leave it because very often it's connected to the leaflet, and by moving it, we get what you have experienced. And the slack on the lead for TTVR is important to understand as well. I mean, I think this case, for ease of managing the lead, and in those scenarios with how much slack you have in our program, it will probably go to a TTVR.
So, but the imaging requirements for, can you talk a little bit about that for evoke versus TIR? I don't think the imaging here is much better. You still need to see leaflets in a bit. Manny, do you want to talk about how you would do the imaging for if you're going to do evoke in this case?
We started with TEs, and it's a nightmare. I mean, it's not easy. For me, TTVR based on leaflet grasping is not the future. It has to be a valve that doesn't depend on leaflet grasping, because tricuspid leaflets are thin and they're often tethered, and it's hard to get around it, get beneath it, and actually make sure. Our initial experience, we ended up with some degree of PVL, and that PVL varied depending on what the interventionist asked me to call it. If it's mild, it's mild. And if they wanted it to be moderate, it's moderate. I mean, I don't know. But now we have defaulted to TTVR because our interventionists just don't feel like they get good results. Maybe if we do difficult cases like you do, Paul, maybe Pradeep and Vivek, all these guys, they might be able to, but somehow they don't feel TTR gives them an optimal result with leads in place. They've struggled quite a bit. And when I say struggled, not technically, but with the results. And so we've defaulted to TTVR almost as a first option, and then TTR as a second option if that's not possible.
Well, I'll let Hursh talk about his paper on leads and the results with TriClip. But maybe you want to finish your case, Hursh, and just tell us what you did.
Let me ask you one question though, Paul, about this. So, and Firas, you made an awesome point. We now learn that taking out the lead. I used to make this comment in conferences. Part of treatment of severe, and Saibal used to say too, part of treatment of severe TR is not a clip, but removing the lead. Because we had these anecdotal cases where it did get better, but for the most part, it doesn't get better. But would you remove it, if you say you're going to go TIR, would you remove it for ease of procedure, like you said, Firas?
I really think it depends on the transgastric view, and it depends on your clipping strategy. If you can see treatable gaps, despite the lead being in place, then we would just leave the lead in place. But if the lead is either in the way of the device manipulation or you cannot see treatable gaps, we would ask that the lead be removed.
So here, I thought here that it was actually creating that gap. I don't know if you feel like that, but I think
agree.
It's creating a gap,
this
right?
looks like lead causing TR, not lead associated TR. And to me, this is a lead removal case. Would you all agree, Nadira? You agree?
Definitely from the transgastric view, you can see it's really pinning it down. So, first option, if lead extraction, obviously with good medical optimization as well, to try and optimize that, So to see what's the next best option. And I think the most important thing which you did as well, before the lead extraction, getting a CT to first see the viability because, of a TTVR in case if anything happens, because you do need the workup before a lead extraction. What is plan B?
Yeah, you definitely, because otherwise you're kind of stuck. If this patient becomes ineligible for repair and you can't replace, then it's unfortunately poor options.
Yeah.
Also, you always assume that the interaction is at the level of the leaflet. Many times, it's subvalvular apparatus.
Right, exactly. Okay, great. So that's what we did. So I asked that lead to be removed. And if you notice, and I don't know if you guys think this or anyone in the audience, but what I've noticed with pacemaker leads that are going through the tricuspid valve, if they don't, and this is me being a amateur electrophysiologist, but if they don't have that curve around, then they're going to sit on that septal leaflet, I think, a lot of times. And you can see this pacer lead is just going straight down like this. And I've noticed that if you don't have, a lot of times that creates late TR. So I had them do this, and then they placed an Avier pacemaker as well. So a leadless pacemaker in the ventricle. And then my practice is to kind of wait 2 to 3 months and see if she got better. She didn't really get better. And then I did another TE, and this is what I have. So I called the electrophysiologist. I said, I think I don't know too much about these leadless pacemakers, but I think it's in the tricuspid valve. And he was like, no. It's like, it's likely just artifact. I'm like, I don't know. You want me to show you this picture? This doesn't look like artifact to me. So it looks like this is in the middle of the valve. So,
We really need some EP doctors in the at CVI next year.
yeah, I know, seriously.
Where's Debbie?
this.
Is she here? Debbie not here yet.
Manny
But
said
then
a
we can't
good
make fun of
point.
them.
We'll have to have Debbie. Debbie's around. We'll have to call her out on this.
Manny actually just said a good point next to me. He said maybe you should replace the EP.
I'm glad he's not here for that. So yes, so this is what I had. So I finally told him, and he was out of town. And so I actually we fixed this on the table. So you can see that it's kind of manipulated. Now it's really on that septal leaflet, right? So the torrential TR is just tons.
Fixed by what? Moving it around?
Yeah.
Hursh?
So have you seen this? You would be interested in this.
I'm really interested right now. I think we all are.
The mechanism on how these guys manipulate this pacemaker is fascinating. The engineering that they've used to snare it, and then they snare it, orient that knob. You can see the knob there. They orient it onto this device, and then it screws in. I mean, if we had that on clips.
It's a one nice thing about this device in comparison to the micro. It's designed to be removed if needed. So
Yeah, and this was my first time doing it, so it's obviously very teachable if I'm doing it. So we manipulated that lead, and you can see the first picture is with the lead in the middle of the tricuspid valve, and then now you can see the wireless pacemaker, not lead, wireless pacemaker is more at the apex. So we decided again 2 weeks later to look at the tricuspid valve. That's a CRT lead. That's not the Avier lead again. So that's just a CRT. So don't worry about that. But look at the gaps now. It's amazing, right? Like with diuresis and removing the stuff that there's a very treatable gap. So we went ahead and treated. So we put one clip in. You can see, and I basically just started anterior septal, as you can see at the commissure, and move. But look the transgastric on the left looks beautiful for another clip. So a second clip, and then we end up putting a third clip. And here's our result. With a gradient of 1 from the beginning, you can see on the left to her saga, which took about 6-7 months later, 8 months later to trace TR.
Do you think the RV got better too?
It did.
Yeah, because that's the other issue about
Yeah.
this RV pacing with the leadless is that the RV gets worse and the TR gets worse. So
Exactly. So, the follow-up was that her creatinine improved, so the end organs improved, and she hasn't had a hospitalization since then. Thank you.
great case. I guess one of the issues with, you've done so many Intrepids, especially right-sided for us and Scott. I mean, when you put these leadless ends, the profile these create, they create problems for the capsule for these devices to be delivered as well for TTVR. And here, this is one that is extending across the tricuspid valve annulus. How do you plan for, if you're going to do leadless, where you're going to put the capsule and such for planning for devices like Intrepid? How do you do that?
Yeah, I mean, I would say definitely when we started doing a tricuspid intervention, the first year was a mini crush training. Like you have to learn the leads, and like the case that you showed where the coils are. Do you gel the coils if you do TTVR, whether it's whatever platform you use? Are the coils at the level of the annulus? Do you have enough slack? Where are you going to position your delivery catheter of the tricuspid so it gels the lead posterior? So you're going to gel it, put it anterior to it, so it gel it posterior, or you're going to do it posterior to it, so it gel it anterior when the valve deploys. So there's a lot of thoughts that goes into the lead. The leadless pacemaker, although thought to be benign, but you're right. I mean, whether it's an Evoke with where you put your Safari wire, or it's Intrepid where you put your capsule, it's important. I think Abbott has also another leadless pacemaker. It's a little bit taller, so it has to go a little bit more on the basal septum, and that can potentially create a little bit more problem, as opposed to, for example, the Medtronic version of it was shorter, that can go more apical. So, you're going to have to talk to your electrophysiologist and learn quite a bit about leads before you do intervention. It's definitely a beast.
No, good point for us. I mean, even the leadless pacemaker, it actually does. We have a series in our center. It's actually going to be presented at coming ESC in a publication that, working with our EP scholars and our EP colleague, that we looked at our leadless pacemakers, and actually the progression of TR is actually quite outstanding. It's pretty remarkable. And we looked at the location of that leadless pacemaker as well as to where in cardiac CT, and it's pretty interesting. And so the data will be out there. So really working with your EP colleagues and collaboration, I think is really crucial. And I think this partnership in your institution, I think is really key into improving, preventing the CIED-related TR, and also in terms of where the location of the leadless pacemaker. So keep a lookout on that.
Lucy, you want to?
I just have a question for the panel, if possible. So at our institution, if we have a patient that we're doing TTVR and it's high risk for some sort of conduction abnormality, we've combined putting a leadless with the Evoke. I'm curious how many other institutions have done that, and also when we are doing these combined procedures with the leadless followed immediately by Evoke, I'm usually in the room and I guide them to where to put the leadless, so it's not to interfere with the TTVR placement later on because of the capsule issue. We've had one case that we actually had to convert from Evoke to TTR because the RV was just too small. The leadless devices are actually pretty big, and it was interfering with the positioning of the Evoke no matter where we put it. So I'm curious to see, how many of you guys are doing, like, do you do TE guided placement of these micros or whatever leadless you do, and have you combined them?
Nadira, you want to comment?
Yeah, so we started 1 or 2 times, and my EP colleagues, I think when they realized that it's really causing, they will call me or one of my interventional echocardiographers to help them in the EP room, to guide them. I would say, yes, I would advocate for it, but certainly in terms of the time constraints for these EP folks, but certainly something that we interventional echocardiographers should encourage, I think, because it is an issue. Because even with leadless pacemaker, you can get TR. So we've a couple of cases. I remember, Paul, a couple of your cases as well. They called us to help. It's not a routine thing, but certainly something is work in progress.
Scott, you guys are you doing echo guided pacemakers?
Not currently. I think we're all happy to help out. I think what this calls out is like how complex these procedures are, what kind of depth of thought you need to get into it, and who and what type of people constitute your heart team approach to treating tricuspid. I mean, it's in depth, like guiding, guiding the implant of a stick that's in the RVOT to get your wire placement or your capsule placement right. So then you have to know the EP procedure. You have to know like the mechanics of placing that, the sheath of that, how they're going. Then you have to understand what type of procedure you're going to do afterwards. And then like all the interventional stuff that then comes following that. This is not just from my standpoint, I mean, this is this is multi-layers of Dante's hell for me and thinking about it. Like, I'm just not wise enough to know all those aspects. But I think it can be built if you have the right people together.
If you're a fellow and you want to do tricuspid, go back to your home institution. Buy your EP colleague some chocolates. You're going to need them.
But it's an important question because of the whole trend towards conduction system pacing. You know, how are we going to do that conduction system pacing in the context of putting in these big devices that clearly straddle the annulus? These are really hard questions that we need a team. Okay, in the interest of time, we'll move on. I think Jonathan? Schwartz? Yes, Jonathan, welcome. Nadira. Wait, Nadira, you're next. Sorry. Let's go Nadira next. You have your next? Sorry. Jonathan, we'll go. We have the wrong order here. Yeah, sorry. Nadira was a late substitute, so thank you again.
Right, so been asked to present this, a case. I just put it together, and on behalf of Akhil, sorry he couldn't be here. And I thought talking about something that the panelists have mentioned just now about, you know, Lucy was saying something about RV dysfunction in TTVR, in tricuspid intervention. When should we really think about this? So this is a 67-year-old gentleman with symptomatic torrential TR, had previous, you know, complete heart block, has CRTP, generator change, lead extraction due to a CIED related, really someone pretty young and have really been through it, and paroxysmal AFib. And looking at his echo imaging, you'll understand why the surgeons do not want to touch him. So here you go. This is what we see. First line, look at how big that RV is. Look how bad his RV function is. I mean, you know, to me, the RV looks dead to me. And this is really the TR. I don't think it's torrential. I call it to these guys tsunamic. This is like Niagara Falls. You know, you have, you know, in the echo, you have that equalization of the RA and the RV. So certainly on Doppler. So this guy has been living out there, you know, clearly symptomatic. And look at the other baseline imaging. Look at the transgastric view. So you can appreciate that RV function from both the mid-esophageal and the transgastric. Very large gaps, not ideal for tricuspid TR, as you can see in the previous two cases. And then obviously we are all thinking, okay, let's do a replacement technology, right? That's the first thing that all of us were thinking. So look at the CT. We look at the perimeter is 165. What are your thoughts, panel?
So Manny, you do a lot of replacements. Challenge here is perimeter is 165.
I don't do them. I just watch them do it.
You know he's going to get back to you.
Perimeter is 165 here. I mean, it's really up there.
Isn't 160 the top? I'm not sure what the cutoff is.
Scott, for us?
Well, I would just remind people that the lifespan of a Fontana is about 30 years, and it's not far off that. So, I mean, this is like, I don't know. You know, these are challenging. This is worse than torrential, so yeah, tsunamic is a reasonable term for it. You know, this calls into just like what were the entrance criteria for RV dysfunction prior to TTVR that we've seen in the TRISCEND 2, and then we just have to go down the pathway of what other imaging modalities do you need besides simple 2D echo to understand that the best. And if they meet criteria, then I think it's reasonable. If there's severe RV dysfunction, then you're having a different discussion. So whatever you can do to figure out kind of the full context of the RV, you know, the relative EF is going to be exceedingly low on this. But you know, the annular motion wasn't awful on this. That I think it's a good discussion. Would this person survive, and how to help them through that with prehab and then post-hab of the RV. There are multiple strategies for that.
Firas and
Oh, come on, guys. Interventionalists are simple people. We barely understand mild, moderate, severe on the mitral side. Now, massive torrential and tsunami on the tricuspid. I think I think from an RV standpoint, what we have learned is the most critical part is immediately after the procedure. Like how to get them through the procedure. There is no doubt that those who do well after peri-procedural, their 30-day, the RV is happier. And the question is how we get them through the procedure. And I think it is all about prehab, maybe inotrope, maybe avoid heart rhythm disturbance, heart block. But in my mind, this is a TTVR case. It probably can be managed with the commercially available devices. And we just have to be very careful with the RV perioperative. Pre-admit, diuresis, maybe inotrope, no beta blocker, strict post-operative management.
I think a lot of that, it's about predicting how they're going to respond. So yes, getting them through it with the inotropes and doing prehab and all those things. We do those because, in my opinion, we don't know how they're going to respond to replacing the valve. We know that these patients are at high risk of RV issues afterwards, but what we really need is an RV stress test. We need some way of telling us that the RV is going to respond to this in this way, and then that'll help guide whether the RV is just going to fall apart. Manny, you want to comment on this?
I mean, RV function and volume overload is simply, we don't understand it. I don't think we will easily understand it. The difficulty is RV dysfunction, myocardial dysfunction, compounded by pulmonary circulation issues. For what it is worth, we need a simple way of what you're talking about, predicting which RV is going to fall apart, which is going to get better after you take away the preload. And that's not easy. One of the things we have found, and it's being published, is a simple 2D index, because that's the easiest thing to do, is septal flattening in systole, not in diastole, but in systole. If there is septal flattening in systole, that RV is almost gone, and it's never coming back. Whereas diastolic flattening and systolic flattening is also bad, whereas pure diastolic flattening, and it's very hard to see that ventricle because we treat TR so late, almost invariably 80% of them have systolic and diastolic flattening, which is a reflection of pulmonary hypertension. And that's the problem. And what we have found is it's a good way of saying anticipate problems in this RV if there is septal flattening in systole. It's not like we don't treat them. We do treat them, unfortunately, because, and I just do wonder, one last comment. With RV, if it's really gone and if there is severe TR, I don't do torrential TR and all that. I do severe TR. And should we even treat the TR or just deal with the venous congestion? Because that symptoms are all due to venous congestion. It's not, I mean, that RV is not going to get better and potentially get worse.
Okay.
Yeah, and precisely your point, Manny. Very good points about that RV septum, because you're going to see this in this case. So this is the right heart cath. So you can see, your RV pressures, your cardiac output, your cardiac index. Not terrible, as you can see here, And so we, the options as we mentioned just now, and to Manny's point, heterotopic transcatheter in terms of unloading that venous congestion could be an option for this gentleman, but we submitted for one of our TTVR. I presented this earlier at New York Valves. So certainly this is one of the upcoming. It's called the V-Dyne. It's a little different from your Evoke. So it's a little gentle. I describe it as like a woman putting her feet into the shoe. So you can see that on the left-hand side. You can see it sliding. So it's really gentle on the base of your RV. And you can see the ease and use of it is really atraumatic. Imaging is really simple, that's what I think, but it's pretty doable. Certain views that we need in esophageal, which I'll show you in a second. So look at the valve itself. It has an RVOT tab, it has an atrial tab, it has the scallops at the side there, literally which we could see on transesophageal and transgastric view in terms of securing it on the lateral wall, and we have a PS tab. So it looks really nice. It does have a pop-off hole where we can create the hole if to unload offload that mismatch if we think during the procedure, if we have that, RV failure. So before this case, we were talking about it, right, Paul? We were talking about using this pop-off hole, and the pop-off hole is literally round, and from echo, you will leave the patient with at least about mild moderate. I calculated on the 3D VCA to offload that, to help that RV. So that's something that we were thinking of going into this case. So intraprocedurally, I like my bicaval 3D view, as you know. As Paul maneuver the delivery of the catheter and the device, you can see it as he opens up in the RA. You can see literally as he tries to engage into that RVOT tab there. So as he tries to push in, like literally like a shoe coming in, as you put your feet into the shoe. So he's really engaging into that RVOT tab. And then going into your other views, transgastric, the same basic view as you know from your TE imaging. Looking at your RVOT tab, transgastric view as well. You can see on the right-hand side, biplane imaging, confirming that it's engaged. And then moving along, as he opened up the valve, try to sit into the tricuspid valve, you can see. And we engage in the posterior tab, and you can see once we fit it in, we confirm it on echo and fluoroscopy as well. We deploy it, we stabilize it, and you can see on fluoro imaging how it looks like on an on-force view on the right-hand side, exactly like how I showed you just now in a couple of images before, looking on the side view and the on-force view. And then what happened to the RV? So look at this post-deployment, and Paul asked me, well, how is it? And I said, the RV is dead. Look at this. We checked with our anesthesia, hemodynamics. She's actually doing pretty well. Was not much pressures. I was pleasantly surprised. I was nervous as looking at this on echo, and we said, let's just wait. Let's wait and see, right, Paul? And the free wall strain, we do that on echo, it's markedly reduced. We know that, but the patient did well. We extubated the patient, brought the patient up, not even to a unit, to the floor. He was walking the next day. We did a CT before discharge, but look at that septum, to Manny's point. It's moving. And you look at the pre and post deployment on the right-hand side, look at the LV, it's contracting much better. And so this gentleman, literally was discharged after 2 days of hospitalization. And I think you saw him in clinic. He's doing remarkably very well. And he's on anticoagulation for his TTVR, but he's certainly doing well. Certainly follow up in terms of his RV, but he really has improved remarkably. So these are some CT images thanks to Joao. So you can see here, really moving very well. I have in the interest of time, I think us as imagers understanding the right ventricle, I think it's such a complex structure. We have 3, images on the panel. Our modality of our favorite is certainly echo, but it's very challenging. We are limited, as we mentioned. And then we are challenged with what is the definition of RV dysfunction, right? 3D RVEF, I think, Manny, is really hard on echo. We are challenged by it, by the lateral view. We have the numbers, we have the new guidelines of RV by ASC. Lucy might comment on that, but then certainly it's very challenging. You have the device and then, it's hard to image it. We have other echo parameters. We have our RVPA coupling that we have been using in a lot of the trials. And it has shown to have improved outcomes. So my previous fellow from Columbia, Brenna, he did a paper looking at all the tric valve registry and saw a cutoff, and certainly is integrated into our defining our outcomes. But are we using it in our clinical practice? And that's the challenge that we have now that we have 2 commercial devices. In terms of other meta-analysis of outcomes of these patients, clinical and echo, we look at this, and you look at the table below, in terms of the transcatheter tricuspid valve interventions to our RV size and what are their clinical outcomes. We are using the basic echo parameters of TAP-C and fractional area change to help improve the forward stroke volume. But I think we can certainly do better. And this is the data from Triluminate, from our data that we presented at London Valves, that if we have baseline RV size dilated at baseline, they are associated with higher rates of heart failure hospitalization, mortality, irregardless of whether they get a TriClip. So these patients are sick. And when we do a TriClip, we actually get RV reverse remodeling. You can see here, down to, if you get a TriClip down to less than moderate, you will get RV reverse remodeling. And this is the data right from our Triluminate data that we presented last year, and the paper will be out end of this year. If you get a 2-grade reduction, you get favorable RV reverse remodeling. And we see it in our sub-study, courtesy of Dr. Joel Cavalcante. So you can see here in the sub-study that these patients actually do well. Once you reduce that TR down by 2 grade, you can get the TR reduction, you have that RV volume change, you have improvement in your RVEF. And so our understanding of RV function for therapy at baseline is crucial. We need, as imagers, when we screen these patients for TR, we need to look at the RV. It does make an impact. Look at the TriClip and look at the replacement technology. We need to do better as imagers. How? Certainly is work in progress. There's a lot of us to do. What is the definition? What are parameters? And in terms of absolute TR reduction, and what are the impact in terms of direct mechanical or indirect hemodynamic effects of these devices in the RV function? And so before I conclude, I think, we need to understand better for RV function and how it impacts in clinical trials, because in clinical trials, we are excluding all patients with this kind of severe RV dysfunction. And so now that we're in the real world, it's a challenge for us, and how we look after these patients with RV dysfunction post-TTVR in the clinical practice. And so certainly something we need to look at carefully, work in collaboration with our heart failure colleagues, EP and surgical friends. With that, thank you very much.
Tell you, so that case that Nadira showed, that one, we had a very intense discussion in our heart team conference, and actually there were a lot of people who said that we should not do it because the RV was so far dilated, and but we also had the discussion that this patient had no options. And I thought the V-dyne worked beautifully, and I believe that it's related to the asymmetry of the device, because the RV is not shaped round; it's shaped like a croissant, and the V-dyne is very gentle. And when we get into that size range, 165, to take an RV and make it circular at that size range, I mean, how do we handle that? I mean, for us, you've done a lot of these. I mean, you were taking croissants, turning them into donuts. I mean, is that the right thing for the RV when it's in that size range?
I mean, you're absolutely right, Paul. I mean, I think the biggest challenge is so far in our journey of tricuspid, we focus too much on the anatomy, right? What valve can fit in this anatomy? Is this tearable? Yes, maybe we'll go tear. If it's not tearable, we'll do TTVR. If we go TTVR, then, does it fit this parameter or that parameter? So it's mainly anatomical. And I think as we learn more and more tools are available, we have to think beyond anatomy. What valve, the valve shape, the valve design, does it or does not require pacing, the risk of heart block, the interaction with the anatomy. The comment about the septum is so true. So I think as we have more tool and we understand the therapy better, we will move beyond just what is anatomically suitable for this specific anatomy.
I agree. All right, thanks so much, Jonathan. Sorry for the delay. Come on up.
No worries. All this talk about donuts and croissants, you're making me hungry. Okay, so thank you so much for inviting me back, Paul. Congrats again on another great meeting. The topic given to me was complex tricuspid valve repair for 2025. I never really know what complex means because things I see here are sometimes a little bit crazy, but we'll see what we got. So is there a slide advancer? Okay. So this is an 82-year-old gentleman, AFib, has a pacemaker. He's got TR, obviously, hypertension, diabetic, lots of other complications here. Was hospitalized for a GI bleed initially, a couple of different hospitalizations with heart failure hospitalization, so really symptomatic. It was actually originally referred for a Watchman, ended up getting that placed. During the time of the procedure, we just wanted to see where his hemodynamics were at because he was having all these hospitalizations, clearly showed volume overload. During the procedure, which was TE guided, showed torrential secondary TR with a pacemaker lead in the posteroseptal commissure, but there was a lot of excess lead that was sort of wrapping around the right atrium that sort of made the imaging a little bit difficult. Some mild PH and mild RV dilation. In follow-up, the patient was doing well from a Watchman standpoint, but noted ongoing dyspnea, fatigue, and edema. So just a quick show of the Watchman procedure. Everything went well there. Very large appendage. This was a 40 millimeter device, but things were good there. And then more interesting is the TR here. You can see the lead there up in the posteroseptal commissure.
All the complex cases today have leads.
It makes for the best conversations and discussions, I think. So, yeah, very appropriate. So, just to label things: posterior leaflet, anterior, and septal with your lead up there at the top. There's a jet between the AS leaflets, and then also a pretty big canyon there in the interposterior area. So, we thought maybe amenable to TIR would be a little tricky, but probably could be done. Did not think he'd be a good candidate for valve replacement because the whole point of the Watchman was to get him off the anticoagulation. Was felt to be optimized on meds, and the repeat echo just showed persistent TR. And we had a review with our team, and we thought we'd give it a shot with a TriClip device. Probably would need 3D ICE, TE and ICE guidance, with some concerns about the lead, but we thought we could just go ahead without having to deal with it at first. So initial pictures, clearly severe TR. You can see the guide coming in there, navigating down to the valve. We started at the interseptal gap, able to get a clip on there relatively easily. A little bit hard to see the septal leaflet falling in, but ultimately got a clip on and looked pretty good. Still had probably moderate to severe residual. We knew we needed multiple clips here, so we come in with the second clip. Initially tried to go right next to it in the interseptal leaflet area. Was very difficult to see the septal leaflet falling in. We were able to get a clip in there, and it looked like there was some TR reduction, but we weren't confident that we had a good grasp of the septal leaflet, so worried a little bit about a SLD. The big problem here was right where we needed to go. You can see the pacemaker lead is right next to it. And so next steps, we sort of talked earlier about trying to manipulate these leads, and we brought in an agilist to try to snare it and move it out of the way. That really didn't seem to help too much, unfortunately. And after about 2 or 3 hours, still weren't able to get a second clip on. So trying to go right next to the first clip was unsuccessful. A lot of shadowing from the lead. The agilist didn't really help a whole lot. We were able to get a grasp in the posteroseptal area, but it really didn't reduce the TR that much. There was still that persistent canyon. So the challenge here, torrential TR, refractory to meds, we got one clip on. We still have probably a massive residual after one clip. Second clip, not confident. What do we do next?
Great case. So two devices, residual TR in between. How would you manage?
There's only one that we left. So
One what?
And we only had one clip on that we
Oh,
left.
only one clip
Yep.
on.
Yep.
Okay.
We took out the posterior septal because it didn't change.
All right, Rishardi.
We could move it, but moving it didn't help. Still had shadowing.
When I use it, the Destino does, it has a better ratchet than an Agilis, so it allows me to take my hands off a little bit more, but yeah.
Yep, we could move it, still had shadowing.
Difficult one. Hursh.
Yeah, we tried that. We couldn't confidently grasp the septal leaflet with the grippers.
TTVR and take out the first clip or leave the clip in. So evoke or something with the clip in place. So
Maybe
elastotear with or no elasta.
The problem with the TTVR though is he can't take anticoagulation.
Oh, so no anticoagulation, and we definitely need that for evoke. Nadira,
Was
you want to
the-
comment? Trick valve.
I would see this as a heavyweight fight, and you have about 5 more rounds of pummeling to go, and I'd probably ask for a break and do some medicines and, come back and allow for potentially a little remodeling, and then do ice again. I think there is probably a septal landing zone there. I would commend you that because you didn't have confidence in the septal leaflet, not to try something to put it there, because you can definitely make things worse with an SLDA and make things even more complicated. So it's sometimes, rope-a-dope and taking your licks and then coming back swinging on another day, I don't think is wrong as long as you realize what you're doing. So I think that's a strategy as well.
Thinking of the Cree valve. Just put it's a spacer with a stent in the SVC, right?
Yes.
Yes, and there's a little, the old version is the Forma, which, we know what happened to it, but then the newer one is the Cree valve, so you have a spacer in the AP canyon.
Yeah, and it's a spacer with a functioning valve, so it's a little bit better than a Forma, but that's an option as well. But I think you need anticoagulation for that too. So
You do.
okay.
Yep. Limited options.
The other thing, was there atrial septal defect related to the Watchman? Anything you left behind
Not
that needed to be
significant.
closed? Okay.
No, yeah,
All right.
not significant. Okay, so we decided just to stop. Good suggestion. After a few hours of this, thought we're not making a whole lot of progress. We thought, well, the lead has been a problem. Why don't we at least have EP look at it, see if they could extract it? They were able to do that. Put a leadless pacemaker in. Patient still had symptomatic TR afterwards that remained massive to torrential. So we thought, well, let's bring them in, try the prehab thing, see if we could optimize a little bit, and then give it another go. You can see here, so that original clip is still there, still have massive TR, lead's gone, a little bit better imaging. We were then trying to go after the posterior septal area. Just like before, didn't really make a whole lot of difference with the amount of TR there. You can still see there's that big canyon in the AP area. It's not often that we go after the AP leaflets, but we thought, well, why not give it a shot and see what we can do? So we've got our ICE probe here. You can see we sort of did the candy cane maneuver to get a little bit closer. Really helps with the imaging. You can see some really nice pictures there with the leaflets falling into the grippers. And then we were successful to get an AP clip on. Sort of left with a 3-leaf clover here, and residual TR was, in the moderate range. Thought that was pretty much a win for what we were able to do with the anatomy that we were given. So got the triorifice, TR was reduced, diuresed a little bit further afterwards, and the patient felt great. Clips looked to be in good position the next day. At 1 month follow-up, everything was stable. Probably had moderate to severe TR still at the end, but gradient was fine. Notice he was much more active, had some stairs in his house that he couldn't do, and then after we got that second clip on, he was able to do that. So not too bad for what we had. So key learnings we thought here, stop and think. It's okay to give it, come back another day if you need to. Got EP involved, that was really helpful. As Nadira showed with her publication, even just getting a 2-grade reduction, you can really get meaningful symptomatic benefit in patients that have severe TR. And then I think the multimodality imaging, as with all these cases, this was a really good example of how that saved us.
Great case. So clipping the AP commissure, what's nice about that is that it's the perfect alignment for the ICE probe. because it's zero, right? So it's the one view that we can actually see a lot with the 4D ice. Technically, Jonathan, you want to comment on maneuvers for clipping in the AP? It's technically a little bit harder because our natural steering isn't in that direction.
Yeah, so you just have to adjust. I definitely lean on our reps a lot when it comes to that, but we've only done it a few times, so I think if we had more experience, maybe we'd learn better.
So it's more of a push and pull, and the F knob a little bit more challenging to steer in that direction. Comments? Anybody from the panel?
One of the things that this brought to mind is, we've tackled some AP commissure ones before. What gives that, I think, this is just personal opinion, stability, is the presence of the posterior septal device. Because now you have an anchor on the posterior side. You basically have an anchor on the anterior side, and you're just using it to approximate those leaflets, and then you'll have less like annular motion without that without that posterior septal device. There's going to be a lot more tension on those two leaflets that I feel would lead to a potential SLDA from that. So I think that's a potential key to investigate.
That's a really good point. So only do AP after you've already got a PS clip on?
And an AP
NAS,
clip.
I'm sorry,
Yeah, you
NAS.
need an AS, a
Yeah.
PS, and then I could probably endorse it. But without that, I think it can become a significant challenge.
Yeah, so essentially you have to A-frame it. So A-frames and then APs otherwise. I never thought of it that way. I always thought about, well, sometimes it's the AP is the only place I can get anything on, but you want to A-frame it first. Good point. Comments? Manny?
About Nadira putting on her shoes differently than men do? Like, I'm just like...
I just want to ask the panel and anybody in the audience who does this, tricuspid valve. I ask this question. What do we think about if there was a relatively easy to implant annuloplasty device? Would it take care of some of these lead associated issues, or will it not do that? What do we think? It's hypothetical. If there was such a device, transcatheter.
I'll take that. I mean, I think your question is, is there a way that we can do this procedure with less torture? Yeah. And I think we thought a lot about this, and we've done, many cases with an annuloplasty therapy. The challenge is when the septal leaflet is very tethered, and especially if it's pinned by a pacemaker. Even though you're approximating the anatomy, you're shrinking the annulus, but still, that doesn't fix the tethered, septal leaflet. So, and especially if it's like completely plastered against the septal wall, like how it is sometimes. In those cases, you definitely need to, either pull it up, to create some a sealing zone, or you're gonna need to exclude it by a TTVR. So I agree with you. I think it works, and if there is one device that is less torture, that would be really welcomed. But I think there will still be scenarios, especially with pacemaker, that are hard. And I think this case is a wonderful demonstration how taking out the pacemaker, not necessarily to decrease TR, but to make the procedure feasible.
Well, I mean, I do like the stabilization parts of an annuloplasty device, because we're seeing our patients back, and if they have residual TR, they can progress, and so a stabilization device would be welcome. I was actually really impressed that you got a clip on that PS area. That septal leaflet was not moving. Very hard. Any tips and tricks for the audience about how to get things on when the septal leaflet's anchored like that? Oh yeah, Jonathan, don't step backwards. You're gonna.
I'm okay. Yeah.
Stay in the circle.
Yeah.
Stay in the circle.
Good. It's hard to generalize. I think every case is different. Just trying to make sure you get under it and not get cords. Visualization is key. So almost always every case we use ice, and I think that really helps.
Great.
Yeah, so the questions about like optimizing with clip, doing one at a time. I tend to try to get both at first and then optimize later. The really tethered leaflets, I don't like to grab those first and then swing. I usually do the other way. So more mobile leaflets, grab that first and then come over.
I agree. I think they tend to be, the things that are immobile tend to immobilize you. And it's very hard to swing over, to be honest. Yeah.
And I think, Jonathan, what you actually diarrhea.
Yeah, diaries.
And I think that really helped in the septal leaflet a lot. Diarrhea, really getting them to a good volume, I think can help with this.
Oh, completely.
So
Yeah.
See?
one
Yeah.
thing about the Tarzan is that when we do that, a lot of times your orientation turns. So that's why I don't like to do it. I like to grab both together and then you could optimize. But when you Tarzan, almost always you rotate.
Particularly with tricuspid. I feel like less so in the mitral space, but yeah.
Our septal lateral movements aren't purely septal lateral. So.
Yep.
Okay, thank you, Jonathan. That was great. Yeah, in the interest of time, we're going to pass over my presentation and go to the final one. Is Gorav here? Yes, Gorav. Well, microphone. Welcome.
All right, good. Well, as the token surgeon, I think I get asked about this, and so I think the title was actually, if somebody can get the slides up, but the title was actually a patient that sort of we wished we'd done surgery instead of transcatheter. I'll have to be honest, we've only had one case that we've had to go in after a failed TTVR was actually on the table, a commercial case, and this was fairly recent. Had I think perforation and malposition, so we operated. And I don't have that case to share, unfortunately, just yet. But maybe next year we'll have. I think that was recorded, and that was not my case. But I want to talk about a couple cases of trying to decide what to do, and obviously, as the surgeon, that's ultimately what they got here. My disclosures, and I think we all know the background of tricuspid surgery. There's a sense that, oh gosh, these are high risk. Historically, in databases, the STS database, they have a mortality as high as 10%. And then we all know part of the reasons we're seeing that on the transcatheter side. The cases that were presented here before, they present late, their RV's dead. And oftentimes, the TR is much more severe before the patient develops symptoms. And it's not until you see the RV dysfunction that they start getting symptoms. And so they often have concomitant valve diseases. So somebody mentioned, your surgeons don't just do one thing to the tricuspid. They also just don't do the tricuspid. There's often times more things that need to be done. And then they all have liver and renal dysfunction. So all these things together really impact survival. So the selection is really important, obviously. So I'll share, this is actually a case from Monday, and he's going home today. So a 77-year-old male, class 2 symptoms, has long-standing persistent AF. So for well over a decade, he'd had a mitral repair at a Midwest center near Paul Sorajja in 2003, and had a sick sinus syndrome, had a pacemaker placed in 2015. I love the comment about, we see all these pacemakers, and we're seeing at least 40% of our cases for isolated tricuspid repair, if not more, have lead induced or lead associated. Interestingly, his mitral ring, and I'm not sure I actually included the images for this, but his ring had dehisced partially, just on the around the posterior annulus, but he only had mild MR. And so that was part of the equation. Do we think about dealing with that? And he had torrential TR due to a restricted septal leaflet, and he had a lead across. So similar to one of the earlier cases, we actually went ahead and had our EPs take the lead out. He was pacer dependent, and so he had a leadless pacemaker, and the repeat TE was unchanged. So we can get this to play. There you go. Okay, how would you grade this, my echo colleagues? I know this is not fair. I don't have the whole echo, so don't tell me if I had all the images, you know.
Well, it's not good.
It's significant. Why don't we just say that? But definitely at least severe massive torrential range.
Okay. I think our echo team called it torrential still. And so some of the other images I didn't keep in here, and I'll show you the 3D, but some of the other sizing, he got a TTVR CT protocol. His annulus dimension was 6.2, and his perimeter was 199. So would that be eligible for any of the new things that you're talking about? No. Okay. Say it again. Out of range for everything?
So it would be out of range for anything orthotopic. So the current devices are around 175, but there are some newer technologies that are going to be up to 220, hopefully soon. So, but it would be outside the range of most.
Okay. What do you guys think about the RV function? I think that's the other question. You know, because now when Paul's talking about some of these orthotopic, heterotopic areas, you know, we're really thinking this is more extreme. This is sort of palliative in a way. What do you think about the RV function here? And again, I know it's not fair. I only kept a couple images to keep it short for a few cases, but
It's not severely decreased.
You never look at RV function on a TEE. I mean, you don't. So to the extent you only have this images, I'll use the English phrase, it doesn't look too bad.
yeah. Yeah, and so it was read as, in all fairness, it was read as mildly reduced but moderately dilated. So you can see it as, you know, at least equal to the size of the left ventricle. And you can get a sense, a little bit of the MR there, but it really was mild. So ultimately, we discussed the matter, heart team, after taking the lead out, and really came back to surgery. And so we have now a series of mitral and tricuspid cases that first are evaluated for transcatheter. That's sort of the first approach. And we just recently published a paper, at least on the mitral side, that their operative mortality is actually lower than you think for patients that are non-operative at first, they're rejected for a transcatheter approach, and the operative mortality back to surgery is about 4% for the mitral side. So this patient, annulus was too large. He had torrential TR, and our team did not feel like he was amenable to tricuspid TR because of the severity, the location, and you know, we went back to medical therapy, and that was maximized. But he says I'm still symptomatic, and he's a pretty robust guy. You know, he exercises, and he's only class 2, so he's not too far gone. And so we did offer surgery, and so his prior operation was through a sternotomy, and there was no adhesions in the lung. And we do a lot of these through the right chest, through a small incision, minimally invasive, as well as beating heart. And I think that also can help with RV function. And there's some emerging literature now coming out that the RV function can be more preserved with surgery when you go through the right chest versus through a sternotomy. There's a paper that'll be coming out that I reviewed in the near future. So any case, we opened it up, and the first thing we looked at this and we said, it's almost like carcinoid. There's no leaflet. There's hardly any leaflet. And so we're doing a bit of a saline test, and honestly, the initial thought was, we're going to replace this valve. You know, that was what he was going to likely get. But as we just started testing, you could see there's actually quite a bit more leaflet. And so the nice thing, we're not under a lot of time constraint, and we went ahead and just to put annuloplasty sutures in. And one thing that's a little different, because he had a pacemaker in, we could be a bit more aggressive about how much of the valve to enclose. So we were traditionally taught to do a partial ring, and this is still a partial ring, but we essentially covered about 270 degrees because he's already pacer dependent, and we're not worried about the AV node and intentionally trying to downsize. So this is a large ring, it's a 36 ring, but remember that's downsized from 62, and it covers about 270 degrees, and that was very intentional. And then during the whole time, we can obviously test, and oftentimes we'll do this, and there's residual TR. I think somebody mentioned there's more we can do. We will oftentimes do an edge-to-edge repair, and so we went ahead and tested again, and you can see there's actually a lot more coaptation. It's completely different in terms of the sizing. And this is his immediate post-op echo. They were having trouble with that before. Let's see. really had quite trace TR. I'm not sure if somebody can play that or not, but trace TR. And some of the other benefits that I think about, I know I've talked about this with a number of people on our panel. When we think about the difference between a repair and a replacement from surgery, what do we do differently with repair? We downsize the annulus, whereas with replacements surgically, we probably closer to true size. Of course, with transcatheter approaches, we upsize, right? So what does that do to the base of the ventricle? I worry about that a lot. So I think we're going to see, in theory, when we're downsizing, we're going to see more remodeling of the RV than we do with oversized prostheses. So at least that's the hope. So this guy's done very well. I was just asked to sign his discharge order, so he's going home. He was on low-dose melanoma just because we want to make sure his RV's okay. Came off that the next day, and he actually had his discharge echo yesterday, and that also shows trace TR. So I'm going to skip this case. This is actually a micro lead causing a perforation, and maybe save that for another time. And just because I think it's important to hear about some discussion. And this is one of the cases I experienced years ago, a patient that had an attempted mitral clip in the tricuspid position prior to any studies being done. And we were so inexperienced, we missed it. We were trying to go anteroseptal, and you can see we went AP, which is really hard to do, but especially if you don't know what you're doing. Apparently it's easy to do. And you can see he had residual TR, and this patient was a patient we did not want to operate on. He's hypotensive on dialysis. They can't get volume off. He's got calciphylaxis. So somebody we didn't want to operate, but unfortunately we kind of were forced to or didn't really have great options. And occasionally you can get a repair. And so we kept the clip in place, did an additional Alfieri, did a ring. I doubt this patient lived very long, but it can be done. And I think we as surgeons are going to be seeing more of these things, more of the TTVR failures. And I'll be honest with you, the TTVR failure going to surgery is going to be a challenge to remove, especially if they're in a while. They're very large prostheses, and I think they're going to be a challenge. So I also want to put a plug in for surgeons. We can do things better now than what the previous databases show. I think it comes with good patient selection. Doesn't mean every patient's eligible, right? And so we're all seeing more of these patients. We're getting more selective. We're prehabbing. We're working in heart teams. That's made outcomes for the entire field better, whether it's transcatheter or surgery. And we can now, with good selection, perform cases with really no mortality when selected well. So in conclusion, I think there's a lot of enthusiasm about transcatheter approaches, and it's certainly our first line in most patients, especially if they're older. But there's limitations, and we heard about them today with TTVR. I think the 1-year results have been okay. We eliminate TR, but we're still thinking about that RV. And of course, anticoagulation. TTR has been variable in terms of outcomes. It can be challenging, and sometimes we get a great result, and man, we feel really good, but it's not always the case. And surgery has more risk. There's no question. It's more invasive. But I do think that with your heart team, please consider surgery at times, in the right patient, because it really opens a lot of options. We can treat many of the lesions, and then outcomes really can be great. Thank you.
Thank you, Gorav. I gotta believe, we're so early in the tricuspid experience. We have had just 2 randomized trials. We have 2 devices only. It's almost like when you think back to the TAVR days, when TAVR came, the mortality with TAVR and SAVR both improved as we both got better experience. I gotta believe that what you're showing with tricuspid and what we have with tricuspid will continue to improve because your techniques get better. We take patients off the table who would be high risk for surgery. We take patients off the table who would be high risk for tricuspid catheter procedures, and it kind of works in both directions. You agree?
I agree, and I think the other, absolutely, and I made that comment as well. I think the other thing is, because now everybody's understanding and focusing a lot more, the denominator of patients has gone up tremendously, right? So that's the first thing, so we can be selective. But now we have, before these trials, we didn't have heart failure cardiologists that are thinking about the tricuspid. We didn't have EPs that are thinking about this. You've discussed this earlier. All those things are really important in terms of moving the field forward.
How often are you prehabbing before surgery?
This patient I didn't, but very frequently. I think, and I'll also be honest, our own isolated tricuspid valve surgery volume has come down with approval of both devices. During the trial phase, we actually saw quite a few more because, their echo didn't show severe TR, yet they had severe or massive TR, or their annulus was too big prior to the 52 valve. So those things together, we were seeing a lot more. So the volume has gone down for isolated tricuspid operations. So given that, we're seeing sort of the rejects of the rejects. And so those patients, I think, are more often we're prehabbing at least 30, if not 50% of the time.
Are you guys doing the same prehabbing?
I'm talking for surgical
For
cases.
surgery? Yeah. How about for transcatheter? How often are you guys prehabbing? Many?
Almost always.
Always for TTVR?
Yes.
Wow. Scott, for us, how often are you guys prehabbing?
I think all tricuspids, it's pretty standard unless that for TIRs or TTVRs that it's prehab, but definitely for TTVRs. TTRs maybe in a selected few, but probably less than 15%.
Wow,
And
so
on
all
day
replacements essentially are getting prehab, it sounds
procedure. Oh, without a doubt.
I would say for our transcatheter cases, it's still a minority under 30%.
Yeah.
And we do have a lot of checkpoints, and as sure all of you do with volume status and things like that, even up till a few days before checking on those things.
We virtually never prehab, believe it or not, even for our
For TIR.
transcatheter, for
For TIR.
tricuspid replacements.
Oh, really?
Yeah, it's extremely rare.
But I mean, you have your team checking on the fluid status?
Yes,
Yeah,
we have people do an H&P beforehand and
Correct.
such, but it's,
Ours is usually within a few days, so we know.
yeah.
Part of it is because of your volume status.
That's what it is, yeah.
Exactly, because when they are out of that, back at home, their weight changes and they go back to their original. And then for the TTVR replacement technologies, right, Paul, it's where the annulus sizes changes if you do aggressive rehab. And so when you do that and the CT actually changes. I think we have a paper coming out, I think, where the annulus size changed dramatically. And so that actually put your TTVR device sizing really changes by one size.
Yeah.
And so we don't know what happens.
Yeah, we're actually a little scared for some of our research cases because we've had cases where the size has gone down a couple with diuresis.
And then you have concerns about putting the smaller valve
Exactly,
in. I see.
yeah.
I would say that the other patient, it's sort of the patient you were mentioning, Nadira, that's sort of just on the borderline. They just make their annulus, the perimeter dimensions, and you don't want them to come in. And those cases, we certainly pre-admit.
Lucy, are you guys prehabbing?
Pretty much all tricuspids we prehab. Now, how aggressive we prehab, whether it's IV or PO, but we bring them in early to take a look. And the annulus can change, but we try not to downsize on the table. We pretty much never downsize. We could upsize, but we would never downsize.
Great. Well, it's been a great start to CVI. Thank you so much for this first session. We'll take